I want to talk today about the important topic of subtle STEMI or occlusion MI. I have given talks in the past related to this under my playlist Myocardial Infarction. There are the EKG talk, ST elevation talks, as well as in the non-STEMI talk and STEMI part 3. I've described many of those patterns. In today's talk, I will describe some new patterns and some new examples, and I will summarize as well some of the basic ideas I described in the past. 20 to 30% of non-STEMI are due to acute coronary occlusion, frequently left circumflex or RCA occlusion, and may be pathophysiologically STEMI equivalent or subtle STEMIs. Subtle ST elevation is a common finding in that 20 to 30% of non-STEMI, along with other recognized subtle STEMI patterns that I will describe. Subtle STEMI EKGs should be recognized and taken emergently for cath and treated as a STEMI, like a classic STEMI, rather than a non-STEMI. Although many of those occlusive MI are on the overlap in terms of perfusion of the infarcted territory, they may be on the overlap between non-STEMI and STEMI, and they may still benefit from late reperfusion. However, they should be taken emergently to cath and addressed initially, similarly to a classic STEMI. Guidelines give cut points to define STEMI, but as I described before, those cut points are flawed. In fact, lesser ST elevation in the right context frequently still implies injury and qualifies for emergent reperfusion, usually PCI, not lytics when you're below those cut points. And conversely, ST elevation above those cut points, above a millimeter or above 2 millimeter in the anterior precordial leads, is frequently not a STEMI. So it's much, much more important to focus on the shape rather than the size of the ST elevation. And there are 5 major causes of ST elevation, particularly for STEMI: early repolarization, pericarditis, and ST elevation secondary to depolarization abnormality from LVH or left bundle branch block. There are 5 morphological criteria that imply STEMI. Any of them implies STEMI. ST elevation that is straight or convex upward, blending with the T to form a dome, such as this one. This morphology suggests STEMI. You have wide upright T or inverted T, so T-wave abnormality, whether large or wide, or inverted T, along with a subtle ST elevation, or you have Q waves, or you have a size of ST elevation or T wave that almost approximate QRS height. And in those patients, what you frequently have, you have a shrinking of the QRS along with a rising of the T wave. So QRS shrink and T rises, so much so that QRS and T almost approximate, or ST elevation almost approximates half of the QRS. So ST elevation approximating half of the QRS, or T wave approximating the whole QRS, suggests STEMI. Then you have reciprocal ST depression, which may be seen in LVH and left bundle branch block. When you have secondary repolarization abnormalities, you will have ST depression when QRS is upright and ST elevation when QRS is down. So that may mimic reciprocal ST depression. And there are 4 major patterns of occlusive MI. I will elaborate particularly on the first pattern, which is the most common pattern and the most frequently missed pattern, which is an ST elevation that is subtle, less than 1 millimeter, sometimes in only 1 or 2 leads, unlike the paradigm that you need to have it in 2 contiguous leads. Sometimes it's only in 1 or 2 non-contiguous leads, and it's mild, less than a millimeter, but the morphology is consistent with STEMI, and you have any of the following: either a glaring or subtle reciprocal ST depression, or not even ST depression, T inversion, or you have evolving Q waves, or you have that shrinking QRS that I like so much. before you develop Q waves, before that myocardial infarcted area becomes electrically inert and becomes a Q, you develop a shrinking of that QRS. So the QRS shrink while you have a relatively large T and ST. The T may not be large in absolute value. The ST segment may not be very high in absolute value, but T approximates QRS and ST approximates half of QRS, a small QRS. That is very suggestive of STEMI. Another feature is upward pull of the S wave, lifting it above the baseline. This is what we call terminal QRS distortion. And I will show you some of those patterns. So this is a patient who's having a shrinking of the QRS along with a wide T. That T is not very wide in absolute value. It's not more than 10 millimeters, but it is approximating the QRS size and QRS is shrinking. That size mismatch is indicative of STEMI. Then I mentioned that S being pulled up by the ST. So when you have a STEMI, QRS shrinks and the S wave gets pulled up by the ST segment so much that the S wave rises above the baseline and is no longer called an S wave, but I still like to call it an S that is being pulled above the baseline. This is very suggestive of STEMI. This is such a case where you have ST elevation along with a wide and relatively large T that approximates the QRS size in lead V2 and even more so in lead V3. And in V3, you have that terminal QRS distortion, that S wave that is getting pulled above the baseline. And as it is always important in those subtle STEMI, always repeat the EKG 5 to 15 minutes later, multiple times potentially, and see the progression. STEMI will progress somehow. The QRS will further shrink. You may have evolving Q waves. You may have a more glaring white T, or you may start having T wave inversion, or you may start having more pronounced reciprocal ST depression or T inversion. So again, repeat the EKG and look for those evolving signs. And this patient, the EKG is repeated, and you have now a full-blown Q wave in lead V3, and you have further shrinkage of QRS in lead V2 and further rise of that T wave, which becomes larger than the QRS. Along with that, you have that S wave being pulled above the baseline in lead V4, and you have reciprocal inferior ST depression. Subtle, but in context, significant. This is an EKG of a 61-year-old woman presenting with chest pain and diaphoresis that started 1 hour previously. This EKG may be read as normal in an asymptomatic patient if you're reading just a stack of EKG, but with her ongoing distress, you have to seek those mild features of subtle STEMI. And in this case, we have subtle Q waves in leads V1 and V2. You have subtle ST depression in the inferior leads. You see it here in 2, 3, and AVF. And you have a wide T wave in V4 and relatively tall T that approximates the size of a shrinking QRS. Also in lead V4, you have that S wave being pulled above the baseline by the ST. So all this is suggestive of a STEMI. This patient was taken to the cath lab, and indeed she had 100% occlusion of the LAD just before a large first septal. And she had CC2 and grade 3 collateral from a large first diagonal branch, as well as from the RCA, as you may see here. And those collaterals and the fact that it probably was chronically severely stenosed before it fully occluded explains why ST elevation is so subtle in this patient. There is some flow to that infarcted territory. That may be why some of those subtle STEMIs are on the overlap between non-STEMI and STEMI. They have some perfusion to the infarcted territory, but they need to be cath and recanalized emergently. This is another case. A 34-year-old female obese presents with chest pain for 3 hours worse with supine position. Even though she's only 34 years old, this EKG has many subtle STEMI features. You have subtle anterior ST elevation with a shrinking QRS and T wave that approximate the QRS size, especially in lead V2 and V3. You have an ST that is only about 1 millimeter elevated in lead V3, but that exceeds 50% of that small shrinking QRS. So ST that exceeds 50% of a shrinking QRS is very concerning for STEMI. You also have subtle inferior ST depression. You also have that terminal QRS distortion, that S wave that's being pulled above the baseline in leads V3 and especially in lead V4. And indeed, the patient had an acute thrombotic occlusion of the mid-LAD just after a large diagonal branch. And you can see here the heavy thrombus of the occlusion. This is another case, 63-year-old female smoker with severe hypertension, no prior cardiac history. She had chest pain for 3 hours before presentation. You can see on this EKG there is mild ST elevation in all of the precordial leads from V1 through V6, especially in leads V4, V5, where it is approximately a 2 millimeter, and where it's particularly discrepant to the QRS size. You have a T wave here and before V5 that almost approximates or exceeds the QRS size. And you have an STT morphology that is convex or straight upward that looks almost like a dome in leads V4 through V6. Occasionally, you may see a T wave that is large compared to the QRS at the transition zone when QRS moves between negative to positive. But when you have it outside the transition zone or when you have it in multiple leads, that becomes even more concerning. You also have in reciprocal leads some T wave abnormality, some biphasic T wave in the inferior leads, which in another patient would not be worrisome, but in conjunction with those findings is concerning for reciprocal abnormality from an anterior MI. Another thing, why would she have ST elevation? She does not have LVH, and early repolarization is unusual in a woman her age. Early repolarization is more common in men, young or middle-aged men. And indeed, this patient had complete mid-LAD acute occlusion. This is another case where we have a glaring ST elevation in most of the leads, and despite that ST elevation being glaring, this is actually not a STEMI. This is acute pericarditis because this patient had none of the 5 features of STEMI. You have ST elevation that is concave, you do not have a shrinking QRS or Q waves, and the ST and T, while large in absolute value, they are small relatively to the QRS in all these. They are nowhere near approximating the QRS size. You do not have T wave abnormality, whether large T or inverted T, and you do not have reciprocal ST depression. Except for the ST depression that is expected in pericarditis, in AVR and a little bit in V1, the leads that look away from the axis of the heart, the axis of the diffuse ST elevation. So this patient has acute pericarditis. Also, ST elevation, while prominent, never exceeds 5 millimeter. ST elevation in pericarditis should never exceed 5 millimeter. ST elevation in early repolarization should never exceed 2.5 to 3 millimeters. This patient has also PR depression in leads 2, V5 and V6. However, PR depression can be seen in acute MI. PR depression does not imply pericarditis if MI features are present. Also, PR depression that is mild, less than a millimeter, may be seen in early repolarization. This is another patient, cancer patient with dyspnea. She has diffuse ST elevation in all the leads with ST depression in AVR, like this prior patient. So this may initially suggest malignant pericarditis. You also have PR depression in leads 2, AVF, and V5, V6. However, having pericarditis feature does not necessarily rule out STEMI. One should search for the 5 STEMI features and make sure none of them is present. In this patient, the ST elevation has a dome morphology with an upwardly convex shape and a wide and high T fused with the ST segment, very typical of STEMI. Also, the size of the ST elevation, over 5 millimeter in V2 through V4, and larger than the QRS, the shrinking QRS in V4 is definitely suggestive of STEMI. And keep in mind that 30% of enteroapical MI cause diffuse ST elevation without reciprocal ST depression, like pericarditis. This is because the apex is seen by all the EKG leads, the anterior leads, but also the inferior leads, which see the inferior apex supplied by a wraparound LAD. This is another EKG shared with me by one of my fellows, Nassim. I love this EKG. This is a 66-year-old man diabetic with ongoing chest pain. At first look, it may seem that the EKG is normal, but look more carefully for subtle signs. And the most important finding to me is here in leads V5 and V6. We have that shrunk tiny QRS in those leads, along with a T wave that seems small, but that is actually relatively large compared to the QRS, and that matches the size of that tiny QRS. So this shrinking QRS with a relatively large T that is equal or nearly equal in size to the QRS strongly suggests occlusion MI. And I get asked, what do you mean by shrunk QRS? If you have serial EKG, you will see QRS progressively shrinking in size and eventually evolving into a Q wave. If you are looking at only one EKG in time, QRS shrinking usually means to me a QRS that is small, less than 5 to 10 millimeters, along with a T that is large in relative terms, meaning it approximates the height of QRS. Not necessarily exact height of the QRS, but close to it. Also, you may have a ST elevation that is mild in absolute term, but it is concerning when it is over 50% of the size of a tiny shrinking QRS. This is not published in those exact proportion, but that fits with the standard STEMI EKG progression. There are more subtle features on that EKG. You have a Q wave in V5, V6 that is small, but that is actually significant and pathologic because it's wider than one box. It's wide, and an abnormal Q wave is mainly defined by its width, more than one box. This is the case here. Also, you have mild ST depression in lead V2. Normally, you should not have any ST depression in V2. If anything, you normally have a little bit of ST elevation in lead V2. Subtle ST depression in V2 suggests posterior STEMI. And if you do, in this patient, record leads V7 through V9, you may find more pronounced ST elevation. Anyway, the constellation of findings in that patient suggests low lateral and posterior occlusion MI, most likely from a low OM. It's unlikely to be diagonal because diagonal you will have typically ST elevation in AVL. And indeed, on coronary angiography, this patient had an acutely occluded OM4, which was acutely recanalized. And now I want to move on and describe 3 particular morphological features that are talked about in the literature. One is that terminal QRS distortion, which strongly indicates STEMI simply because it is not seen in early reportization. And it consists of lifting that S wave above the baseline, so it's no longer really an S wave. And in those patients, it's not just lifting the S wave above the baseline, there is also no J wave. There is a sharp J point. There is no J wave. So compare this to the earlier polarization here, where you still have an S below the baseline and where you may have a J wave, not just a J point. So this is a case I had where I had ST elevation along with an S wave that is being pulled clearly above the baseline in these V3, V4, V5, V6. However, unlike this here, there is a J wave. It's not just a sharp J point, there is a J wave. So this tells me this may very well be earlier polarization. If you have an S pulled above the baseline with a sharp J point, this is not earlier polarization. But when you have it with a J wave, it may be earlier polarization. And indeed, in this patient, this is his full EKG. This was earlier polarization, and this was based on the fact that he had the same EKG a couple of years ago. He also had negative serial troponin. And note that with earlier polarization, ST elevation is usually not that high, but it can be up to 3 millimeters, particularly in younger men or men who are athletes or African Americans. In the STEMI case I showed earlier, look at this, S lifted above the baseline and you have a sharp J point. You don't have a J wave. Here, sharp J point. S lifted with a sharp J point. And this is from the paper by Dr. Smith that fairly standardized that feature. And here you can see S lifted above the baseline with a sharp J point. In that paper, they did not define how many patients with lifted S wave and sharp J point are STEMI. They just showed that nobody with early polarization had that pattern. Now, there is a second pattern that is being talked about that I want you to recognize. It's called the South African flag pattern. And in that case, you have an ST elevation in two non-contiguous leads, in lead AVL and lead V2, along with inferior reciprocal ST depression. So ST elevation in AVL and V2, sometimes in lead 1. This is very suggestive of acute diagonal occlusion. And this is why it's called South African flag, because it can fit within the colors of a South African flag. So you have ST elevation in AVL and V2 and ST depression in lead 3 and in the inferior leads, and sometimes ST elevation in lead 1. So again, suggestive of diagonal occlusion. Now, this is a third pattern that's being talked about. This is what we call the Aslanger pattern. So in this case, you have diffuse ST depression, particularly in the lateral leads, 1 AVL and V4 through V6, sometimes pronounced ST depression, along with ST elevation in one lead only, usually lead 3, sometimes also in V1 and AVR, but mainly in lead 3. This pattern is suggestive of an inferior occlusive MI, OMI, along with critical concomitant non-culprit disease. So what happens, the critical non-culprit ischemia will cause diffuse profound ST depression, while the occlusion in the inferior territory will cause ST elevation. This ST elevation in one territory and concomitant ST depression from the anterior ischemia will attenuate the inferior ST elevation, except in lead 3, which is furthest away from the anterior wall and from the anterior wall ST depression axis. So it's basically negation of the inferior ST elevation by the ST depression caused by anterior ischemia. However, this is the pattern that to me is the weakest in terms of suggesting occlusive MI, because the concern is that many of these patients rather have acute subendocardial ischemia from left main or LAD disease, along with CTO of the RCA or left circumflex, not acute occlusion. The CTO of the RCA receives collaterals from the LAD. So when the LAD gets ischemic, the CTO territory gets even more severely ischemic and develops subtle ST elevation along with the diffuse ST depression attributed to the left main and LAD ischemia. So it's a subtle ST elevation from diffuse subendocardial ischemia that is more pronounced in the territory of a CTO. So we need to take those patients urgently to the cath lab, but don't feel compelled to intervene. Analyze your angiogram carefully, and if you believe there are grade 3 or CC2 collaterals to an occluded RCA, it may be CTO of the RCA with ischemia because of acute, non-totally occlusive LAD disease. You may stop and consult for cabbage. Don't feel compelled to intervene. Again, Aslanger pattern out of all those patterns is the one that is least strongly suggestive of OMI in my experience. And not just my experience, based also on the Aslanger paper, where patient with Aslanger pattern had a troponin that is way lower than the STEMI troponin, 2.3 versus 34.8 troponin. Although their troponin was higher than the classic non-STEMI. And also the Aslanger patients, only 25% had an acute occlusion here, and 25% had a chronic total occlusion, which fits with my concern that many of those patients have just diffuse subendocardial ischemia and a CTO in one territory that makes ST a little elevated in that particular territory. This is another such case that illustrates my idea. This is a 71-year-old man who's presenting with acute chest pain. He has diffuse pronounced ST depression along with ST elevation in V1 and AVR and ST elevation in lead 3. This patient actually has left main or 3-vessel diffuse subendocardial ischemia with CTO of the RCA. So the ischemia is more pronounced in the inferior wall. When the left main gets ischemic, the RCA, which is being fed by collaterals from the left, gets more ischemic than anything else and gets so ischemic that you develop some degree of ST elevation injury in the inferior wall. This is not primary RCA STEMI. You need to take this patient to the lab, preferably urgently. And if this patient is having active massive pulmonary edema, you have the time probably to stabilize him, diurese him before rushing him to the lab and decompensating his heart failure furthermore. Try to stabilize him if he's not stable yet. And as I will describe in a little bit, diffuse ST depression with ST elevation in V1 and or AVR is not a STEMI equivalent. It is suggestive of profound ischemia, potentially in the left main, but it's not a STEMI equivalent. So we don't need to rush those patients to the cath lab. Unless ST abnormality is profound and persistent, which was the case of this patient. That is why we took him urgently to the cath lab and found severe left main and LAD disease along with RCA CTO as we expected. This is another Aslanger case from the literature. And in this case, with that ST elevation in 3 and ST depression in the lateral leads and somewhat diffusely, as well as ST elevation in AVR, this patient did not have an acute occlusion. He had a critical left main LAD disease and not a full occlusion. And that caused something similar to the Aslanger pattern. So again, beware of that pattern. It's not always OMI. Now, I described the first and most important group of OMI, which is a subtle ST elevation with morphological accompanying features suggesting STEMI. I will describe the 3 other ones. Number 2 is what we call hyperacute large and wide T waves, which also fit to some degree with the features I described under 1. The T wave is not necessarily tall in absolute value, Most importantly, it is wide and almost fused with the ST segment in one convex dome, or it is tall in relative term. It's almost the size of the shrinking QRS, especially if associated with a shrinking QRS, or subtle ST elevation, or subtle reciprocal ST depression. One subtype, the de Winter hyperacute T wave, is characterized by an upsloping ST depression in leads V1 through V6, followed by a tall upright T wave. Unlike the classic typical hyperacute T wave, that de Winter pattern somehow never progresses to ST elevation. So those patients are stuck in the phase of hyperacute T wave even as their MI evolves. It doesn't have to be the de Winter hyperacute T wave. Any of those wide and or relatively tall T wave are concerning for STEMI. Then the third pattern is ST depression that is maximal in leads V1 through V4 and which indicates posterior OMI. Typically, it's ST depression in V1, V4 along with an upright T wave in those leads and frequently a prominent R wave in at least one of the leads, V1 or V2, could be prominent in height or in width, and it's reciprocal to a posterior Q wave. Then you have the fourth pattern, which is left bundle branch block or LVH or ventricular pacing with a discordant ST elevation more than 25% or concordant ST elevation. So this is the posterior MI where you have ST depression in leads V2 through V4 along with an upright T and frequently a wide and or tall R wave in leads V1 or V2 reflective of a posterior Q wave. This is the de Winter hyperacute T wave here in the anterior precordial leads. You have that tall T wave exceeding the height of QRS in leads V2 and almost in lead V3, along here with the Q waves in lead V2, V3, and along with reciprocal ST depression in the inferior and lateral leads. And along with ST elevation in AVR, which indicates basal septal injury as in left main or proximal LAD, and in this particular case, it was a proximal LAD. And be careful, distinguish de Winter T waves from Wellens T wave. De Winter T waves are anterior STEMI, whereas Wellens T wave are non-STEMI. Wellens T waves are those biphasic positive negative T waves in leads V2 through V4 with a sharp downslope of the T, almost 90 degrees between the upright and the negative portion, or deeply inverted T wave in those precordial leads preceded by a straight or convex ST segment. Those Wellens T wave indicate LAD, critical stenosis, unstable stenosis, but not STEMI. And this is not an indication for emergent cath. This is a post-ischemic finding in a patient who at some point likely had ST depression or ST elevation, but now is having the post-ischemic T abnormality. Now I will move on to the fourth group of OMI, which is left bundle branch block with ST elevation. I've given talks about that in the past. Keep in mind that acute new left bundle branch block is rarely seen with acute MI. It was seen in 1% of acute MI in the Gusto trial, simply because the left bundle is supplied by the LAD and the RCA. It has dual supply, so it's difficult to infarct the left bundle. And in new left bundle branch block is much more commonly a progression of a cardiomyopathy, whether ischemic or non-ischemic, chronic cardiomyopathy, rather than an acute MI. That said, left bundle branch block is problematic in terms of STEMI diagnosis, simply because left bundle branch block causes discordant ST changes. So when the QRS is down in those precordial leads V1 through V4, ST will be elevated. When the QRS is up in those leads 1 and AVL and V5, V6, ST will be depressed. So imagine somebody has left bundle branch block and anterior ST elevation MI. He inherently has ST elevation from the left bundle branch block. How to know whether within that ST elevation there is also hidden a STEMI type of ST elevation? If you have concordant ST changes, meaning ST depression in leads V1 through V3 or ST elevation in 1 or AVL, that is a STEMI. Now, the issue is that anterior STEMI from proximal LED occlusion may only have ST elevation in leads V1 through V4, which would be discordant to the QRS without any concordant ST abnormality. Even inferior STEMI may only have discordant ST elevation with a down-looking QRS. How to tell if that isolated discordant ST elevation is a true STEMI? The way you can tell is by looking at the ratio of that discordance. What is that discordant ST elevation to QRS ratio? If the ST elevation is large, even more than 5 millimeter, but the ST elevation to QRS is less than 25%, this is just an ST elevation from left bundle branch block. This is not a STEMI. On the other hand, if you have ST elevation that is more than 25%, even if it's not marked in absolute, as in this patient, this ST elevation here is about 2.5 millimeters, but it's way more than 25% of the S or the QRS. This is a STEMI. Here too, you have an ST elevation that is about 3 millimeter, but it is more than 25% of that QRS. So this is a STEMI. So the old Scarbosa criteria use 5 millimeter discordance to suggest a STEMI. That turned out to be insensitive and non-specific for STEMI. So use the relative discordance as I've described in one paper and as described by other authors such as Dr. Smith. Also in my paper, a T-wave discordance, meaning a discordant T that is over 50% of the QRS, was also suggestive of STEMI. So ST that is more than 25% of QRS and T that is more than 50% of QRS. This is such an EKG of left bundle branch block with a STEMI. You can see here the QRS is down, there is discordant ST elevation, but that ST elevation is clearly more than 25% of the QRS. In fact, it's almost the size of the QRS. Here, it's more than 25% of the QRS as well in V1. And in lead 1 and AVL, you have concordant ST elevation, and in the inferior lead, you have concordant ST depression. So concordant ST depression or concordant ST elevation are suggestive of a STEMI in the setting of left bundle branch block. Even the ST depression by itself, if it is concordant, suggests STEMI. I want to explain why is ST elevation so mild in those occlusive OMI or subtle STEMI. There are various explanations. The most common explanation in my experience is that you have some flow to that infarcted territory. You have either some spontaneous recanalization, so the artery is not 100% occluded, it's 99%, or you have a subtotal rather than total occlusion, or you have subacute occlusion with good collateral flow and ischemic preconditioning, like the case I showed before, where the patient had LED occlusion, but CC2 collaterals from the diagonal and from the RCA. This explains why the ST elevation is more subtle and why the troponin may not rise to STEMI level, albeit it rises more than non-STEMI levels, but not quite to STEMI levels, and it may benefit from late PCI. So those subtle STEMI, even if you ended up cathing them late, they would still benefit from late PCI hypothetically more than STEMI. These patients are on the overlap between STEMI and non-STEMI, although again, you should recognize those patterns and perform urgent cath and recanalization. If you happen to not recognize it, they would still benefit from a late cath, hypothetically more than STEMI, because there is some perfusion to that infarcted territory. Another explanation why ST elevation is mild is late STEMI, in which case the EKG pattern would be like this. You will have deep Q wave with minimal residual R wave. So that's another case of subtle STEMI. This is such a case where you have mild ST elevation, but with deep anterior Q wave, and you have reciprocal ST depression. You have also mild ST elevation with a shrinking QRS in leads 1 and AVL that also suggests STEMI. Now, this EKG with deep Q and mild residual ST and R suggests late STEMI presentation more than 24 hours, but it may be an earlier presentation with a spontaneous recanalization. So I would not exclude a benefit from revascularization in this patient based purely on the EKG. If this patient has a history of presenting more than 24 hours ago with no ongoing chest pain, and this EKG, I would call this mild ST elevation because it's a late STEMI. However, an earlier presentation should be considered if symptom onset is described less than 24 hours ago, or if the patient is still having ongoing chest pain. In which case, you need to take that patient emergently to the cath lab and recanalize the occlusion emergently. Now, moving on, the third explanation for the mild ST elevation in those subtle STEMI OMI cases. Again, the first one is the most important one in my opinion. But the third explanation is that the MI area is not well seen by 12-lead EKG, such as posterior and lateral MI. But again, we have that ST depression in the anterior lead that will hint to those. Or you have a small MI territory that is not well seen by the EKG, or you have a concomitant STEMI in one territory, example, the inferior territory, and diffuse ST depression from ischemia of another territory, which attenuates the ST elevation, as in the Aslanger pattern. And in that third subgroup, such as the Aslanger pattern, as I explained, many of the patients have diffuse non-STEMI ischemia, along with CTO of the RCA or left circumflex, which makes the inferior wall have subtle ST elevation. So we need to take those patients urgently for cath, but don't always feel compelled to intervene. Analyze your angiogram carefully, and if you believe there are grade 3 or CC2 collaterals to an occluded right or left circumflex, it may be CTO with ischemia because of acute non-totally occlusive LAD disease that supply collaterals to that CTO. You may stop and consult for CABG. Also, in a patient with severe acute decompensated pulmonary edema and a pattern of mostly diffuse pronounced ST depression and subtle ST elevation in 1 or 2 leads, like that Aslanger pattern, consider stabilizing the patient and diuresing him before cath and seeing if EKG improves with heart failure and oxygenation improvement. Do not feel even compelled to take him super emergently. One last note on ST elevation in AVR. Diffuse ST depression in more than 6 lead with ST elevation in AVR and V1 is not STEMI. It frequently indicates a high-risk non-STEMI with suggestion of diffuse extensive subendocardial ischemia from left main and or 3-vessel CAD. That ST elevation in AVR must be accompanied by ST depression in other leads. It's not just ST elevation in AVR. This is not a STEMI or OMI. Now, the explanation for that pattern is when you have diffuse subendocardial ischemia in all leads, you have an ST depression vector that is in this direction. And you get reciprocal ST elevation in the northern leads, in the leads looking away from the heart, such as V1 and AVR, and sometimes in lead AVL, the so-called northern leads. So you get that northern ST elevation. In addition, injury at the base of the heart from critical left main or proximal LAD will cause ST elevation in those northern leads, V1 and AVR. Now that diffuse subendocardial ischemia, whether from 3-vessel or left main disease, will cause ST elevation in both V1 and AVR. However, in the case of left main, you will have more pronounced ST elevation in AVR than in V1, whereas in 3-vessel disease or in critical proximal LAD, you will have ST elevation in V1 that is equal or more pronounced than AVR. This is because left main critical disease and ischemia cause a counterbalanced ischemia of the proximal LAD and the left circumflex, the posterior wall, so that you do not get as much ST elevation in V1. The ST elevation in V1 gets attenuated by that posterior wall injury, whereas ST elevation in AVR remains very pronounced. So ST elevation in AVR that is more than AV1 or more than 1.5 millimeter is more suggestive of left main than LAD or three-vessel ischemia. So again, that diffuse ST depression with ST elevation in AVR and or V1 is not STEMI and is not even always left main or three-vessel disease. It may be a global ischemia from profound demand supply mismatch, such as severe anemia, severe prolonged hypoxemia, profound hypotension or shock from any source, even without any CAD. And it's commonly seen transiently post-cardiac arrest, even cardiac arrest with no CAD. It may also be seen with severe hypokalemia. So secondary ischemia without extensive CAD is at least as commonly the cause of this EKG versus primary ischemia. And in this paper in American Journal of Medicine, 10% of patients with diffuse ST depression and ST elevation in AVR had acute occlusion, and 40% had no CAD. They had that secondary ischemia I told you about. 60% overall had severe CAD. So around half the time, this pattern may reflect secondary ischemia, not primary CAD ischemia. Now, do we need to cath these patients urgently? Not necessarily. Urgent cath is needed only in case of deep and persistent ST abnormality. For example, persistent over 30 minutes or so, in the absence of a context of demand-supply mismatch like severe anemia or non-cardiogenic shock.